Hello everybody and welcome to the UK Biobanking Showcase for 2020. Hopefully you can all hear us okay, and for your information, this session is being recorded, just to let you know so that we can transmit this to other people who weren't able to attend today. Next slide please. So a very, very warm welcome to you all. I mean, last year we held this in Nottingham, and obviously to current circumstances, we've had to hold this one virtually, but we still hope we can reach out and say hello and give you a handshake, even in a virtual sense in these crazy times. Please use all the tools that we have available, including Hoover, which is apparently how you pronounce it. And so get in contact with us, message us, talk to us, and we're here to engage and to talk to you. Next slide, please. To Sharon, just to do a quick introduction to our sponsor today, and so you can find out more about them as well on the exhibitor pages. So over to Sharon, please.
Thanks, Phil. Interactive Software is really proud to sponsor this first session of the UK Biobanking Showcase 2020. Next slide, please. COVID-19 continues to impact every aspect of our lives. And with more people working remotely than ever before, the need to access information anytime, anywhere is essential. This is especially true for those involved in the fight against COVID-19, who are working together and sharing valuable data and resources. And sharing data securely has always been at the heart of what biobanks do. Achiever Medical web-based LIMS helps biobanks make their samples and information more accessible to collaborators and researchers, giving them what they need to make every sample matter, whether it's through its links to the online UKCRC tissue directory to publish samples, or by using its online researcher portal to streamline the tissue request process. Achiever Medical is also helping biobanks to kickstart their digital transformation by removing paper-based systems, optimizing their processes, connecting to instruments, and improving their data quality and accuracy. Available on-premise or in the cloud, Achiever Medical can be accessed by authorized users anytime, anywhere. Next slide, please. So if you're finding your data and processes challenging or are looking to streamline how you work, then please pop along to our virtual booth or chat to us to see how Achiever Medical LIMS can help your biobank. Thank you very much, and I hope you enjoy this first session and the rest of the event this week. Thanks, Phil.
Thanks very much, Sharon. So on to the next slide, please. So the overview of today, I mean, there is a COVID-19 focus to it. So Emma will be doing a general introduction actually to the platforms, and then going on to talk about what we experienced within COVID. I'll be giving you an overview of the year, but more actually thinking about what we do in the coming years, and that'll be something that we're going to be pushing. And then Amir from TAPb, the biobank, who was very active during COVID, will also give his thoughts and impressions of what was happening. So over to Emma, please. Thank you.
Hi, everyone. Next slide, please. Good afternoon, everyone. My name is Emma Lawrence, and I'm one of the engagement managers here at the UKCRC TDCC. And I thought before my main talk, I'll just do a bit of an overview of what we've got coming up this week. So tomorrow we have a panel discussion on sustainability and transparency. We have 3 excellent speakers, and then there'll be chance for you to pose your question to them afterwards, so that should be really engaging. On Wednesday, we have a workshop on developing common biobanking documentation. You should have all received some pre-work by email to do for that. So if you could just have a look at the documents you've been sent and pop in some of the themes you've thought up into the Wover community thread. I'll show you where that is in just a moment. On Thursday, we have another workshop on redesign biobanking, so that should be really fun because we're going to be doing some blue sky thinking and seeing how we would reimagine biobanking if we could start from scratch. And then on Friday, we have a marketing consultant who is joining us to talk about developing an online presence, and we'll be announcing UK Biobank of the Year, so that's really exciting. Next slide, please. It's a shame that we can't meet in person this year, but we'd really like to make it just as engaging and give you a chance to network. So we're hosting an informal meetup at 4 p.m. each day. So later today, we're going to be talking about communicating remotely. So if you have any top tips about communicating or working remotely, or if you have some challenges you'd like to pose to your colleagues, please log in and join us And then throughout the week, we've got other topics such as communicating costs to users, inducting new users, and recruiting public members to panels. So please log in and join us later. Next slide, please. Hopefully by now you've all familiarised yourself with Hoover, but if not, I thought I'd do a quick tour to show you how to join. So what you should have done today is come to Agenda and then click on the day you want to join. The main session each day is at 1:30, and then the daily meetups at 4 o'clock. So you click on which one of those you want to join. You can join in Hoover or Zoom. If you're having any technical difficulties, then I've put the link here to join in Zoom directly, but please don't share this link with anyone who hasn't registered. If you have any questions for the speakers, please can you use the Hoover Q&A. We're channeling everything through this so we can keep the conversation going after the talk and the streaming has ended. And if you have any technical problems, then use the chat in Hoover. There's other options in the online platform, so you can network with fellow attendees and also start discussions in the community tab. Next slide, please. So if you have any topics you'd like to discuss with your colleagues, then you can start a new thread on the community thread. And there's also loads of existing chats going on. The groups that you've been assigned to do your pre-work in, you can log in and post your results here. So as you can see, group 6 is supplying data. Someone's already logged in and put the themes that they've picked out from the pre-work. So please do take the time to go and do that before the session this week. We'd also like you to take the time to check out the exhibitor profiles, which you can do also on one of these options here. Next slide, please. We've been really lucky to be sponsored by Achiever Medical, BC Platforms, NBF Scientific, Seismex UK, Module Bio, Griner Bio 1, and Ultimus Lab this week. So if you could log in and look at their profiles and then take our quiz, you might be lucky enough to win some chocolate. So please take the time to look at those decks this week. Next slide, please. So now I'm going to be talking about some work we've done this year to coordinate COVID-19 samples in the UK. Next slide, please. So if we can all cast our minds back to March, we were beginning to talk about COVID-19 cases early March in the UK. And quickly, by the 17th of March, UCL staff were encouraged to work from home wherever possible. Now, I know some universities had reacted before that. So at this stage, I think we realised that biobanking staff and biobanking infrastructure may be affected by some of these restrictions and closures. So on the 18th of March, we emailed all 220 UKCRC Tissue Directory registered biobanks to find out if they were going to be remaining open and what the state of their operations would be. On the 20th of March, the full lockdown was announced, and during this time we were advertising to researchers that we were going to be trying to help coordinate and access COVID-19 samples for them. On the 24th of March, we sent our first digest email, so we sent requests that we'd received from researchers out to biobanks that were able to collect COVID-related samples. We did a follow-up mail out to biobanks on the 27th of March. The 2nd of April, the first samples were sent to the first biobank researcher match that we had. So this was just within 2 weeks of our first email, we were able to pair up a researcher with a biobank who could collect samples. So we were able to respond pretty quickly. We did one file mail out on the 6th of May, and I'm going to show the results of these emails in a moment. So these are the results of our mail out. We had 81 people who didn't respond, 17 were open but with relatively normal capacity, 33 had reduced capabilities or staff, and 89 biobanks were closed. This was about 40% of biobanks in the UK were closed at this time, so I think it was clear for us that research and the ability to acquire and distribute samples was going to be impacted by these closures. Next slide, please. We tried to capture some of the reasons for the closures, and not everyone responded to this, but it's typically reasons like you'd expect, either a site closure, staff reallocation, or staff were encouraged to work from home. Next slide, please. So we continue to be quite proactive in trying to find samples for researchers that were looking for them. We looked at NIHR priority studies, so these were studies that had been given priority status within NHS settings, and we looked at the 16 interventional studies that were obviously providing interventions on patients, so because we knew that they would be coming into contact with the patients anyway, and will already be consenting, obviously. So out of the 13 with emails that we were able to contact, 5 responded and 3 were collecting but weren't able to share the samples they'd collected. And then the other 2 that responded said that they weren't collecting samples. I guess it just, in reflection, is a bit of a shame that they didn't collect because, of course, there was limited supplies of samples and they were already coming into contact with patients. In May, we looked at HRA-approved studies that would be using human samples. We contacted 30 and spoke to about 12 of those, and 7 said that they may be able to share, and so we were able to send out requests to them, but 5 said no. So just to say that, as well as being in contact with normal biobanks, we tried to get in contact with other studies and work that was going on to see if we could try and get samples to researchers. Next slide, please. So in total, we received about 40 requests from researchers for COVID-19 samples. And this was really, really high for us, and we normally only get a few come directly to us a month. So it was definitely something that we noticed, was that there was demand outstripped supply. But just to focus on a couple of success stories, we managed to coordinate a partnership between TAPb, Cambridge Blood and Stem Cell Biobank, and Tissue Solutions. Essentially what happened was TAPb, which is a biobank based in London we're going to hear from next, were able to collect blood from COVID-19 patients, but they didn't have the Cat3 facilities to process the blood. And so we were lucky enough to partner them with Cambridge Blood and Stem Cell Biobank, who kindly offered to process the blood. And then Tissue Solutions were on hand to deal with all of the logistics and legalities, because neither of the biobanks had time to deal with those, given everything else they were doing. So that meant that we could get samples out to the researchers that needed them. Another great win for us was that Wales Cancer Bank amended their ethics to support COVID-19 research. We had requests from researchers who needed serum from prior to January 2020. And so we were able to advertise that fact, and Wales Cancer Bank amended their ethics and were able to supply residual serum that wasn't needed. And that was used as a negative control for testing kits for a diagnostic company. So we'd like to say thanks to all of them for the work that they've done, and it just shows that if we coordinate, then we can get more done. I think that's pretty much all from me. So I'm just going to hand back to Phil. Thank you. Next slide.
Thanks very much, Emma. And we can see that obviously the last few months has really been dominated by COVID for us, and I expect so many people on this call. So that's why we're focusing so much on COVID today. In terms of the polls, we do believe it's because of Hoover is not allowing those polls to come through, whereas if you connect directly to Zoom, they do. So I wanted to give you a little feel for our own thoughts about what we do next, because the UKCRC Tissue Directory and Coordination Centre has been going now for 6 years. We've been doing quite a lot of work in making biobanks visible, but the real objective of what we're trying to do is to actually make biobanks accessible and to facilitate access to biobanks. And if we think about the COVID scenario, what it really has done was stress test the system. It really revealed where things were, shall we say, suboptimal in terms of what we were trying to achieve. But from that, it's actually given us some real focus of what we maybe should be looking at next as a national centre. So if you go, sorry, next slide, please. So we think about the lessons learned over the last few months. I think if there was ever an example of why national biobanking infrastructure was needed, COVID has just proven that without any question. It is clear that the ability to handle samples at scale and link it to data is just incredibly vital at the moment. But actually, if you think about it, there is no equivalent to something like NHS Digital, where data can come in, be brought together, and be made available to the research community. We don't really have that for samples. There isn't that coordination in terms of the actual access to the samples. And this has really made us think about how we coordinate, because at the moment, a lot of the coordination that happens from our perspective is retrospective. So we are asked to coordinate after people have been funded, after the ethics is in place, after the consent forms have been written, after the patient information sheets have been written, and after the access committees have been formed. And then we are meant to be able to coordinate to make access easier. Whereas obviously, all of those things I've just mentioned define how access will actually be enabled. So we really need to think about how can we proactively coordinate rather than being seen and placed as a retrospective coordination effort. I think the other thing that has really come through is the need for federation, both of data, so being able to make sure data can be brought together that's not necessarily in one big database, but exactly the same as for samples. We couldn't bring together all the samples into one location. It's probably not desirable to bring all the samples together in one location. So we really need to think about how can we federate out the infrastructure, but making sure that it is coordinated in a proactive way rather than a retrospective action. Next slide, please. So what we have really been considering is it time to fundamentally question the ecosystem that we all operate within? And this is something that I think we're all going to address, and it is something that's really picked out the topics of this week for the showcase around the ecosystem itself, around consents, around standardization, and what can we do next? So great that we can make data sets and samples visible, but how can we make it easier for people to access them? Next slide, please. So some of the things that we hear quite often. So sustainability is impossible. It probably is, it may well be. Our consent form does not allow that. Our ethics does not allow that. We do not have the capacity. Our access committee said no. Patients do not support industry access. We hear this a lot as the National Coordination Centre, and this is not a criticism of how everybody operates. Sustainability is unquestionably a challenge. And yes, consent forms and ethics written in certain ways will have certain restrictions. But why do we have them? What's the bigger picture? And how can we change the system to make this much more simple for researchers to gain access to samples? Next slide, please. So one of the concepts that we want to introduce is Industry 4.0, but for biobanks. How can we integrate to a point where the systems are so interoperable and that the components are understood? It's the Internet of Things idea, meaning that we can bring everything together in a simple way without necessarily removing any delegated authority. How can we work better together in that interoperable space? Next slide. So one idea is around a single national consent form. Now, this is an idea that has been around for some time, but we never quite got there. But why do we need different consent forms? Why is the consent different between different biobanks? Why can't it be that if somebody applies to UKRI or MRC and they get funding to collect samples, that they're not simply handed the consent form that is used? Why do we repeat the effort of drafting consent forms and going through ethics every time? Why do we have that duplication? Why do we have that variability of consent for the patient as well? The terms and conditions for one biobank might be completely different for another. Why do we do it? And I think that's something that we need to look at. And this may be something that we can't achieve in the very short term, but we really should be thinking about it. And the advantage of something like this is that we could allow proactive consenting. If you looked at how the public responded in such a positive way to the call for participants to be available for testing of the vaccine for COVID, why can't we also do that for biobanking? Why can't we have that proactive consent in place on a national standard consent form? Let's see if we can do it. Next slide, please. And obviously the other big part of all of this is the access procedure. You know, at the moment, if somebody comes to the directory and they find 5 different biobanks, most likely they've got to go through 5 different access procedures. So is there a way that we can just have a single access process? Now, this doesn't mean that we get rid of all the access committees, but how can we standardize and harmonize that access process so to the researcher, there is only one? How do we build that process? How do we build the interoperability around access to make that much more simple for them? Then when it comes to things like COVID, we can actually prioritize access through to those studies that really need the samples. This was one thing that we really struggled with. We were just inundated with requests, but we had no way of prioritizing access for those requests. And often the people that got the samples were the people that had the connections rather than the people that needed those samples most. And of course, we've got to think about how do we remove that burden from researchers. So next slide, please. And a key point when it comes to sustainability is around how do we make sure we reuse the existing infrastructure? So one of our frustrations is that although we're trying to reduce duplication, there is no check in the system yet if that infrastructure already exists. So as a researcher, you can apply to a funder, get money to set up your own biobank and collect your samples, repeating potentially the infrastructure that already exists potentially in the same hospital or university that that researcher is operating within. And that is perfectly acceptable. How on earth can we have a sustainable system if we repeatedly refund the same infrastructure that's needed across the country? How can we change that dynamic? What do we need to do to make it so that biobanking is sustainable? And obviously one of those ways is not to have so much duplication and to make sure the funding supports the infrastructure. And we've got some interesting talks tomorrow on this around how they've done it in different domains within medical research, but still in a slightly different domain to biobanking, how that has been achieved. So there again, it's not about removing kind of these biobanks, but how do we make them work together? How do we work together more so that we can facilitate the reuse of the infrastructure rather than the refunding of infrastructure? Next slide, please. So I guess one question that we all need to consider, and I'm more than happy, we've got questions coming up, but also ping me on Hoover about, can we actually do this? Is this achievable? Are there a few of you here willing to start working with us on these processes? Can we get this going? Next slide. Of course, the other question is, do we want to do it? Is this something that we think the community should be trying to target and should be trying to make change? Can we do this together? Are you willing to do this with us? Because obviously as a coordination center, we can't do this on our own. We do need the support of the whole community. So will you work with us on this particular challenge? Next slide. So there's the message. Let's do it together. Let's reach out, work together as a community so that we can really start to challenge those excuses often that are passed back to us around the consent doesn't allow it, the ethics doesn't allow it. Let's change that dynamic. Let's go for it. And so thanks very much. And I think we're going to move on to a Q&A for these sessions now. Next slide, please. Yes, so Q&A is in the Rover app.
So I don't think we've had many come in yet, Phil, but I wondered if we could maybe talk a little bit about, like you were talking about, prioritising the samples and how you would go about that if with samples that are limited supply, in comparing things like companies like diagnostic companies that may need a smaller number of samples, but it's quite important to get those things generated early on, versus something like a cohort study where the samples are larger numbers of samples are needed, but they're not sort of necessarily needed right up front.
Yeah, so I mean, UKRI and NIHR did run a prioritization process for projects where they kind of classified the ones that they felt were higher priority. But the challenge from what I saw was that those projects already exceeded the capacity of the system to supply samples. So the priority was already too much. And so if you're a biobank, you wouldn't be able to have enough samples for those few priority studies, as well as, you know, other things that you might be trying to support. So, and that's where I mean that the missing component to me in that proactive kind of coordination was the ability to be able to actually understand what is the capacity in the system to collect samples. and then make the best use of them. So, multiple studies were running to collect a lot of the time just blood samples from an individual that had a confirmed COVID case, to then process that down into various different derivatives of that sample. But that was done on a per project basis. But why didn't we just we couldn't, but if we were able to coordinate up front, we could then ensure that when one blood sample was taken, that the derivatives from that were used in as many projects as possible, rather than what happened where research teams themselves were collecting samples and were focused quite rightly on their own research project and the samples for their research project. But that meant we lost that overview. So we need to prioritize the projects, yes, but also make better use of samples as they're going through, and making better use of those contacts. So if somebody is going into consent, having to put PPE on and get the consent of the person, why send in another individual for another project using another set of PPE? And I think Amir will kind of talk this in his own presentation about some of these challenges, but that's what was happening on the ground. And we needed that proactive engagement to prevent some of those kind of bottlenecks in the system. So yeah, it's not a simple answer, and it's not simple to get it right, but I think we do need to start thinking about this much more seriously.
Phil, may I ask a quick question, actually? In your talk, you said that lots of researchers have reported that patients are unwilling to provide samples to industrial researchers. Now, from our experience and patient engagement and things we've done, that isn't the case. And we very, very rarely have patients withdrawing consent or denying consent on the basis of commercial research. So I was wondering where that information came from. I'm not saying that it's not justified, but I was just interested to know where you've heard that.
It's a common experience that is said to us. And also, if you look actually at the very initial conversations with the public in terms of the joint work with Ipsos Mori that was done by the HTA and HRA, if you just ask the question, do you support industry access? The answer is no. If you ask the question, do you support industry access in order to generate treatments for a particular disease? The answer is yes. And I think, it's how we present it is important just as much as how you ask the question. And I think that's where some of the time people say no, but by industry and commercial, they're thinking about the whole commercial space. There'll be the technology companies, there'll be the insurance companies. It's not just the pharmaceuticals or the SMEs in that space. And so once you ask the question slightly differently, the support is there. And it is just this discrepancy that you see. And there's a question in the Q&A about this, about how do you manage the differing access restrictions across the country. And this is one of the fundamental problems, because they vary so much. It is really quite hard. The one biobank might have the samples and they need access to 5, but one doesn't allow this type of access, one does, So bringing that together to actually form a consortium of biobanks that would actually allow access is very hard for researchers, because they have to understand the nuances in each consent form. I'm just going to see if we've got any others.
Yeah, we've had a couple more come in. Someone's asked, how would we manage different levels of consent? For example, we asked for consent for additional samples and excess diagnostic samples.
So this is one of the things we want to pick up on Wednesday, is to look at what pieces of information is going to be sufficiently generic that could well be credible for a consent form, that's more of a national consent form, and what pieces of information do we think need to be very specific. So I don't have the answers. But we are starting to look at this, and this is why on Wednesday that we started to start drawing out some of these topics of what is important, why is it important, what is sufficiently generic, what needs to be very, very specific, and start to understand that much more. So these are just our thoughts. These are our immediate response in terms of what happened within COVID. And now we want to put it out to the community to understand, how much is this something that we can do together.
I think one important point related to that, and something that we've been experiencing recently, is ethics, NRES ethics boards. Quite often we find their approach to non-interventional studies, which I think is most of what we're describing here, is quite varied. So some will accept relatively generic ethics, which allows for future ethically approved research, and others want something which is very specific, often for good reason, so the patient really understands what they're consenting to. But then it does, so, there's a balance here, and sometimes that balance doesn't enable those research samples to then be used. And I guess one example is that the Wales Cancer Bank then had to go and get extra ethics to allow their samples to be used for COVID, when obviously when they were initially collected, COVID didn't exist.
Yes. So I'm just getting some things in the chat as well. So yeah, so I think some of these questions coming around, how is it best to interact? And there it's quite interesting. So that was the work from Emma on the survey of researchers, where actually researchers do value the conversations they can have directly with the biobanks. And so that's a clear support service that they look to undertake there, so I think that's an important thing that we need to also consider around how we do this and how we facilitate the access. But that's, to me, this is about how we build a system so it can all work together, rather than thinking we have one system, if you see what I mean. And it's how we make the systems work better together. How are we doing for time? I think we're getting close. Yeah, so I'm now going to hand over to Amir, who was a little champion in terms of COVID research at the time. So he was one of our main biobanks that were able to access samples at the time. So I'm really looking forward to what you say here, Amir. So over to you.
Thank you. The little champion down at UCL and the Royal Free. So my name's Amir Gander. Roberta, do you mind I think you just click along to the end of the slides. I think it might be easy for your finger. So I run an initiative called Tissue Access for Patient Benefit. I think to some extent, lots of what I'm going to talk about will feed into some of the comments already made. And this is very much a case study. And I want to first give an overview of what we actually do as an illustration of why we're not actually very well placed to help provide COVID samples to researchers, but we did it anyway. So Roberta, next slide, please. What is TAPb? So we are an initiative that enables patients and research projects to be linked together. We don't store samples or provide samples unless there is a funded research project associated with it. So that's where the sustainability part comes in. And we aren't core funded by anybody. We do cost recover. And if anyone wants to talk to me more about that, please do get in touch. We work on what's called a long tail organizational strategy. Now, for those who may not know what that is, this is often used in the area of search engine optimization or business strategy and things like that. Long tail is as you can see from the graph, it's a tail shape, so that's the reason for the name. And it's a rank frequency distribution. And so one example would be if we replaced sample events with a number of unique products and sales on the x-axis, someone like Zara, who sells clothes, would be short-tailed, and someone like eBay would be long-tailed, where eBay sells lots and lots and lots and lots and lots of things, but at a relatively low frequency, whereas Zara sells a small number of things at high frequency. So this is my opinion. What I've written on this slide is my opinion. Please do shoot me down if you think it's incorrect, because I'm sure there's lots of the people on the call are involved in some of these projects. But it's really to illustrate where we sit in the landscape. So if we look at sampling events and a number of research samples, I would consider groups like UK Biobank and Genomics England and Japan Biobank as being short-tailed. So very big infrastructures, often core funded as far as I'm aware, can provide very exciting big data and big samples, but have a set criteria of the samples that they collect. And a huge range of different samples within that parameter. But then if you kind of move to the right a little bit, Wales Cancer Bank becomes a little bit more specific. Breast cancer now becomes even more specific. And then the Pancreatic Research Fund, so you're moving to the right a little bit more, where the samples are more specific, and so therefore the requirements are more specific, and the number of researchers that might be interested in might be fewer. And then you have the Baby Biobank, that should be the UCL Baby Biobank, in fact, and the MECSF, which are more even more specialized, so fewer researchers, and often the samples that are being collected might be a bit more specialized. Now, right on the right-hand side there would be us. So what we tend to do is collect very specialized samples for very small numbers of researchers, and we bring together academics in the clinical pathway to really try to facilitate the translational research pipeline very, very aggressively. So if you could go to the next slide, I think it will illustrate what I'm trying to say a little bit better. Yeah, just go to the end, I think might be easier. Thank you. So I'll give you examples of each of these, and I hope it will illustrate what I'm talking about, and then it will give you an indication of why this was difficult for us to pivot from doing what we do to providing COVID samples. So one example I could give is the academic research expertise. So we work at the moment with a device manufacturer and an academic researcher who's in the same department, division of surgery within UCL. And they require extremely specific samples from patients with renal cell carcinoma and collected in a very specialized way. And we have to have very constant communication between the expertise of the academic group, the expertise of the device manufacturer, and what we do in theatre and pathology and other places to ensure that the samples that we do deliver and the clinical data associated with it are very specific and of particular research value in order to enable them to move towards validation of that study. Now, one of the crucial parts of what we do is work with the clinical teams. So quite often people come to us with, let's say, for example, a biomarker. Now, often a biomarker that may well become a diagnostic at some stage might not be, might not fit within the standard of care of what the patients see at the moment. So sometimes the standard of care would inhibit the expression of that biomarker. Now, if earlier on in the research, the researchers are aware of that type of problem, so that as they move forward, when they are trying to put it through validation or clinical trials or whatever, that they can amend the research approach to take in consideration standard of care, that information becomes very, very valuable and enables the research to happen much more quickly and much more effectively over time. And in order to do that, we work with clinical trials units, again, to fit between that early research and clinical trials phase, and we liaise with them quite often to ensure that the data that is being generated from the academics and from external researchers as well, with the clinical knowledge that we possess, to really make sure that that can actually be effectively used within the clinical trials setting. But we also try to have a flexible pricing structure. So for some, a price per sample is much more effective. For others, it is unaffordable. And so we try to implement a subscription model so that it shares the risk of samples being available over a long period of time. So from a budgeting point of view for small, well, for SMEs and for diagnostics and for academic groups particularly, that is advantageous because their outcomes and outputs are generally longer term, whereas often with pharma companies, for example, or some other researchers similar to that, they might want a reasonably small number of samples in a short period of time, and then they assess and reassess. So the structure that we have as a funding model tries to fit within the structure that is out there in the industry. Next slide, please, Roberto. So our COVID response. So what we effectively did was move from being a long-tailed model to a short-tailed model. Now, we're quite expensive. I don't know if any of you remember the Stella Artois adverts, reassuringly expensive, but we are quite expensive because of the specific nature of what we do. Now, our intention is to try to move towards a model and address that issue to enable one research participant to provide samples to a varied number of researchers to reduce that cost. But that expense was a problem within our COVID-19 response. Next slide, please. So just to put it into context, this graph, I know it's a small font and everything, this graph just gives you an idea of the number of patients that we had come through. Now, considering we're one hospital, there was still a reasonable number of patients coming through. And one of the issues here was the total suspected and total positive. And I'll come on to the reasons why that was important in a moment. But as you can see, the peak was, we had a huge number of patients, which was extremely challenging for the hospital and therefore challenging to us. Next slide, please. And this is just to give you some ideas of the activities within our hospital. So one of the take-home messages, I guess, from this slide is the number of, the percentage mortality rates. Now, of the mortality rates, Royal Free did quite well, but still, it's actually very high. And that, again, was very challenging. I mean, in one way, for our staff, it was very challenging mentally to see patients pass that you've only just spoken to and things like that. But also logistically within the hospital, that caused an enormous number of problems. These were some of the research projects we were also involved with. Next slide, please. Now, this is a word map, which I thought would be probably the best way of highlighting some of the challenges. There was a lot of anxiety. Just nationally, there was a lot of anxiety, and within the hospital, it was almost to the point of terror. Now, there's lots of positive messages here, thankfully. So obviously, thank you is one big one, but you can also see some quite difficult things like PTSD. There's PPE there. The idea of having to be resilient, being in a very awkward situation. The canteen one is the thing where we got lots of free food, which was greatly appreciated. But yeah, the purpose of this is to show the context in which we were working in. Next slide, please. Now, as far as I'm aware, and the poll actually challenges this assertion, we were the only biobank that was providing samples to projects that were not already established or clinical trials. Now, it seemed like a very lonely existence at the time, and if we weren't aware of other people who were collecting, and I would like at the end of this to know why that is and whether we can make sure that that doesn't happen again, because it would have been great to work with lots of others. But of the patients which were available within our trust, we managed to get 28% of the patient population. Now, partly that was due to lots of the patients being in ITU beds, so intensive care unit beds, which we didn't have the resource at the time to consent to patients who are incapacitated. So we weren't able to access those. So we took a very targeted approach. So we did use some of our long tail methodology. And that was, we would ask the clinical teams to identify suitable patients based upon researchers' requirements. And then we would move that towards academic colleagues and ourselves to discuss, to translate effectively what the clinical teams were telling us into what the researchers would probably most likely want. And then we would target those patients accordingly and consent. And overwhelmingly, the patients were, despite being very sick, overwhelmingly in favor of participating. We had a minuscule non-consent rate. We did manage to get 300 patient samples to researchers, and through the TDCC, we had strong links with HDR UK and Public Health England and Tissue Solutions, which was already discussed. And without them, we wouldn't have been able to do this. Next slide, please. So this is the way it worked, and I think this has been described to some extent already. So the researchers would come to TDCC. We did have some that would come to us directly, but then we would provide that information to the TDCC to send out a national call. And then working with Tissue Solutions, we were able to deliver the samples in the way that I just described, in that kind of targeted format. Next slide, please. Why don't you just click through it? It will save your fingers. Thank you. So the lessons learned. There were so many logistical issues that I would be able to give a whole presentation just on those, and they seemed relatively minor at the time, but lots and lots and lots of minor issues became lots of big issues. Some of the major ones were lack of PPE. I remember Matt Hancock saying that there was literally a military response to the lack of PPE. Now, we took advantage of that military response, and I have to say it was not forthcoming. We managed to source it, but we had to source PPE directly from suppliers in Turkey and China, and that was a challenge just in itself. And we had lack of adequate training, so quite often the goalposts changed. So in the early days of the pandemic, staff were instructed that it was okay to treat patients with COVID just having a surgical mask. Now, I'm sure a lot of you have to wear surgical masks on public transport and in shops and things. I wouldn't be confident going in front of a coughing patient with just a surgical mask. And so therefore we had to go against some of the policies that we were given. So that's the point about the changing goalposts, and we had to gain external training for infectious diseases to make sure that our staff were safe, and to report on that. None of our staff got COVID, despite them being in constant contact. And also there was a huge challenge around patient testing. So a lot of the researchers required the patients to have a positive test. Now, quite often the patients would be clinically COVID, so in every single indication they would have COVID, you know, the temperature, the cough, and lots of the other blood results would suggest COVID. However, the COVID PCR test would come back negative several times over. Now, I'm sure you're all aware of the false negatives and things, and that caused a huge problem for us, particularly from some researchers who, and I can understand why, demanded that they did have a PCR positive test. So that was an enormous challenge to try and overcome, and that was done really through liaising closely with the researchers to try to explain the situation on the ground. Next slide, please. So what if? I should have made this slide imagine, I think, because it's John Lennon's 80th birthday recently, and I think that would have been quite fitting. But anyway, so what if we had greater coordination across the UK? Now, as I said before, we weren't aware of anybody else that was collecting samples, and we, within the trust and within the university, were unable to process our own samples. And because each patient can often cost hundreds of pounds to collect samples from, and again, I can get offline, I can go into why that costs that amount of money, but it can be very expensive. If we are able to provide samples to lots of researchers from a single participant, then we can make the whole system much more affordable, particularly in the context of diagnostics, who don't necessarily have the same research budgets as other groups might. And also academic researchers that quite often require just a bit of preliminary data in order to be able to get grant applications put together and be more likely to be successful. And also shared facilities. If we are able to work with other people to do the processing much more effectively and to put the patient data, to add patient data to put the samples into context, I think we would have been much more successful and meet much more of the demand that we had. In addition to that, we were one hospital, and if we were able to work with other hospitals, share expertise, share some of this training, share some of the knowledge, I think we would have been able to do things much better than we were able to do. And ultimately, the UK still has a world-beating research sector. I mean, in terms of diagnostics, if we were able to service diagnostic companies better, I think that that's an area of growth within the sector which could be very good for UK PLC as it were. But it ultimately comes to research output, and I do believe that if we were able to work together better, I would suggest the TDCC is a perfectly placed to do that. The research output would be significantly greater, and I'm sure that we could put our heads together to make a justification for that. Next slide, please. So if you click through, this is the research team. So Barry Fuller, Brian Davison, Nathan Griffith, Carolina Ramos, Diana Keterenga, Akshay Mohan, Craig McPherson, Tanya McChain, Natalie Goodtroy, Steph Bogan, and Kira Fraser. I wanted to say all their names out loud because they were absolute troopers, particularly Diana, who's the bottom, on the third along on the bottom. She was on the wards every day in unbelievable situations and did an enormously valiant effort to get researchers those samples. So thank you very much for listening. I look forward to your questions.
Thanks very much, Amir. So we have had a few questions come in. I'm going to pick one up that was actually in the Zoom chat. And I know this was something that we also spoke about quite a bit at the time. So this question of consent and how were you able to do consent for patients that were really quite ill? I mean, so did they have the capacity to consent? But also the fact that they didn't have family members there. So how did you cope with that situation?
So most patients, well, when it comes to capacity to consent, our SOPs, there's a whole thing for capacity consent, but very broadly, we always check with the clinical team to make sure the patient has capacity to consent, and also that the staff are trained to assess that. I mean, obviously being in London, we often have patients whose English isn't enough for them to be fully informed, and so those patients patients that don't have capacity consent we would not target. So that's the first thing to say. Those who were very sick, so we did have the ability to take verbal consent. So that's one amendment that we did, where patients were unable to write, which is surprising, but quite often because they were shaking, they had such high fevers, they were shaking, they were sweaty, they would find it difficult to write. So we would have a witness. So the team would go in twos, and you'd have one person taking the blood and basically doing everything with the patient, but you'd have another person there to witness the whole thing, and they would sometimes take verbal consent, but then obviously document it.
Brilliant, yeah. And if you could have changed one thing, what would it have been?
Oh, blimey. Change one thing. Well, to the resource to be able to work with other people. So processing the samples, we had a Cat3 facility. So the university didn't allow us to do the processing. We had Cat3 facility, but that took ages to get up and running. And it was mainly for internal research. So it would have been really good to work with other hospitals to have the resource, maybe giving TDCC the resource even to work with other hospitals and people who could process the samples, so that we could take the 300 that we provided and make it 3,000.
Yeah, so there was another question linked to that actually. Were you at capacity or was it, the processes and the startup? Because I think you said you got 28% of the cases. I mean, so could you have collected more, or was it?
Yes,
okay.
We could have done. Yes, we could have done. I mean, it changed throughout as the pandemic developed. It changed. So, for want of a better phrase, at the peak of the pandemic, it was almost like a shotgun approach. We did target a bunch of patients, but it was very much, patients were moving around the hospital constantly. So we did take as many as we could, just with the logistics and the resources that we had. But as the numbers reduced, we became even more targeted. But lots of the patients we weren't able to access because they were in ITU, so that would have been probably around 30%. So of the remaining 40% of patients that we missed, it was just simply down to resource.
And did you have any, I presume this means staff, but staff that were afraid to work? Was there a fear factor then? So how did you overcome that?
So our staff, well, so in the hospital generally, there was lots of staff who had underlying health conditions who were either reassigned or into non-COVID facing roles. So that was the hospital policy. Within our staff, to be honest with you, the vast majority were able to step up and do it. There was one or two who did feel uncomfortable doing it, and that was again mainly because of either they had vulnerable care responsibilities, as in a vulnerable person at home, or they had underlying conditions themselves, and so we would put them onto clinical data gathering or something like that. But the vast majority, and as I said, particularly Diana, who should be on the honours list in my opinion, she was really up for it.
Thank you. And so we had a comment coming in the chat around expressing some frustration, basically, that although they could have collected, they just effectively simply weren't allowed to. So how did you overcome that?
Well, initially we were told we weren't allowed to, and what we did, we just made the case to the university, particularly the NHS were okay with us working with them because of some of the studies that came through that I put earlier, and I'm sure lots of the people here are also involved with their national and international studies. So the hospital were okay with us working, but the university weren't. So we just went to the provost and said, this is what we do, and it's crucial, and brought together external, I don't know how to say it, powerful people, I guess, or people with influence and understanding of what we do, to ensure that the university had the confidence that we weren't causing ourselves or our colleagues risk. And then we put in measures to mitigate for those risks.
And linked to that also was the same person was commenting that actually because of the amount of studies, actually they were prioritized. So the research studies were prioritized rather than a biobank. So did you have a similar challenge where a study was trying to operate and collect samples, and therefore the biobank couldn't have access to the same portion of patients?
Yes, we did. And so what we did was we worked with them. So quite often, particularly with studies that come through the CRN, and for those who don't know what that is, these are hospital studies which are linked with NIHR, and they tend to have hospital staff, who are permanent staff who collect samples or do whatever for the studies. And they tend to be, in a non-COVID context, they tend to be clinical trials and things like that. So that infrastructure was often used to collect samples, but lots of those nurses weren't necessarily used to going onto infectious diseases wards. Many of them didn't have the training to get onto infectious diseases wards. So what we did was we went to the people who were running the studies and worked with them. Again, to mention Diana, because she doesn't get enough mention, she has had the infectious disease training. She worked with Ebola when we had it in the hospital, and various other studies similar to that. So she really knows how to work into those types of wards, and she supported them. And we also supported the clinical teams as well to help them collect samples for routine clinical bloods. So it was basically through collaboration we were able to persuade those studies to work with us rather than in competition.
Yeah, brilliant. And I know this was also something that we talked about a lot of the time, was around the need for a category 3 facility. And it's picked up in the chat around the session. There's been some responses there, but what was your experience of the advice that was available about whether it was needed a Cat 2 or Cat 3?
Sorry, Phil. My headphones just died. Let me just... I didn't hear the last part of the question.
Yeah, so it was around the category 3 for blood samples. How did you find out at the time in terms of the advice that was available about whether this was needed, be Cat 2, Cat 3, and also how the local institute kind of implemented that policy?
Well, I think disproportionately. So the university, that was one of the things they would not budge on. It was us using the Cat 3, or us using Cat 2 facilities for the blood samples, despite there being evidence to suggest that blood samples don't carry or are of minimal risk. So there were compromises in us being able to work. So we were forced to do that. And of course, now the policy has changed and we can use Cat 2 facilities. Now that is just for blood samples, of course. With other samples that have got live COVID virulent in it, we would not be able to, we would need to still use the Cat 3, but it took a long time. So we do have a Cat 3 on site, but it took a long time for them to move from what they normally do, which is tuberculosis research and I think HIV, and they were also involved with the Ebola study too. It took them a long time to change their ability to pivot towards taking COVID samples, and a lot of it was down to the number of patients that we had and the throughput that we required. They just weren't set up for that number of patients in any one time. So by the time that they were on board and were able to work, the peak had gone. Does that answer the question? I'm not sure I actually did.
I've done the mistake of mute. But then where did you get the advice from? Did you feel that was sufficient in terms of what the policy should be, or?
Well, the advice came from the university, and the university, I'm guessing, got that advice from the government. Interpreted the government advice, which at the time was Cat 2 for diagnostics and Cat 3, well, Cat 2 for diagnostics and Cat 3 for others, and they've interpreted that, I'm presuming for litigation reasons. I don't think it was. I think that if the university, and I don't want to criticise them necessarily, because of course they have to protect the institution and the staff, but I think they could have been much more proactive in trying to find a solution, but they weren't. And I'm sure that that's the case across the UK from other people I've spoken to at different universities.
And then one from me, actually, in terms of, I know you were trying really hard to get samples out. We had to do that relationship between yourselves, the facility in Cambridge, and Tissue Solutions to get samples out. So that's probably quite an unusual situation where you've got one biobank collecting samples, one biobank processing them, and another biobank operating the logistics. So how did you find that all working together? So
well, I think it forms a really good model for work for going forward. I mean, there were some minor issues that we overcame, but it was very good. It was really useful. We wouldn't have been able to do it without the TDC and Tissue Solutions at all, because of the issues that I raised. You know, we were so busy trying to mitigate for the local issues, and as I already alluded to, we don't normally work in this way. We don't normally have like a very specific, this is effectively short tail organizational structure providing these samples where we aren't really structured that way. So without that interaction, we couldn't have done it. Now, moving forward, it means that we could hopefully find a way in which we can be much more efficient generally in providing samples, so that we can achieve the goal of one participant providing samples to several researchers, which the vast majority of research participants that we speak to are massively in favour of.
So what would you do different next time on that? Is it to make sure some of those agreements are already in place? Because that must have taken a bit of time as well, or what could be done?
Yeah, having some of the agreements already in place. Again, I think it comes down to the resource of the tissue directory. I think and it's not just resource in terms of financial resource, but I think it's also, I think some of the things that you alluded to, where if let's say the funders and the regulators and and the other stakeholders involved in this sector, if they were to be more aligned and enable the TDCC much more actively, then I think the whole sector would be much more efficient anyway. So I think it is, and I don't mean to criticise, because I don't think it's something which is done consciously or even maliciously or anything like that. But if we were able to move towards that kind of structure where we were able to have let's call it the moral support, is probably the best way of putting it, from the different stakeholders, I think we would be, the TDCC would be much more effective. And I think from a biobank point of view, that would, from our experiences with COVID, that would be hugely beneficial.
Yeah, thank you. And we're grilling you now. So there's another question around the couriers. So how did the couriers respond when you're trying to transport samples? So how did they respond to handling COVID samples? Were there any issues there? What did you do?
So the COVID, so again, the government recommendations were UN 337, 3373, sorry. And we did that plus. So we went the extra mile to, I can't remember off the top of my head all the different bits and pieces, but if anyone's interested, I can send you our SOPs. But we went over and above what would be normally required for UN 3373. So the couriers were fine with it. And they're quite used to carrying samples such as this. So for them, as long as there's, we made sure the samples were on the outside were sterilized and all the rest of it. So yeah, they seemed okay.
Brilliant, thank you. And so yes, they would like your SOPs.
Right, okay. So get in touch with me and then I can send them over to you.
Yeah, so I think that's the end of the questions for you. We have tried to capture all the session questions in the session Q&A in the chat on Hoover as well. So there might be some more there for you, Amir, if you could reply to them. And we are trying to make sure that after the video part ends, that we can still continue some of these conversations. We have also got the drop-in session later today. So if you want to use it, there's no planned speakers, but if you just want to come in and say hello to everybody and chat, we've got those sessions later in the afternoon as well. So you should have all of that in the...
I'll be there.
Brill. So that's it, I think. So thank you very much for joining us on the first day. We've learned a lot about the systems and when polls appear and polls don't appear and all the rest of it. So we'll make sure we improve during the week. Try and have a look at what we're doing on Wednesday around the consent form. So there is a bit of work there to do around what concepts we think should or shouldn't be in those consent forms. Thank you very much to Interactive Software and Achiever Medical in terms of sponsoring today's session. By the sponsors doing it today and for the whole week, it's meant we've been able to keep it free for everybody despite having the platforms and cost there. So thank you very much. So I think that's it. Thank you. See you all tomorrow. If we don't see you in the afternoon session, just to catch up and say hi. So thanks very much.